Well, good evening, everyone. We're so glad to have you with us tonight. My name is Charlene Margot, and I'm founder of the Parent Education Series, the program brought to you by nonprofit The Parent Venture. We are delighted to have with us tonight Dr. Samantha Bureau, who's going to be talking to you about brain trauma, concussion, and CTE. What should families know? This is a very important topic, and if you're here tonight, we know that you have probably been personally impacted either by yourself or with one of your kids, or through sports or athletics, or perhaps an other kind of accident or incident.
Thank you, Charlene. Thank you, everyone, for being here. I do have a PowerPoint presentation, so I will pull that up. But yes, I'm so happy to be here, and I hope you are all able to learn something new by the time we're done our session, or at minimum, have a new appreciation for the topic. So I appreciate everyone tuning in. So as I mentioned in the title of the talk, we will be reviewing a couple of topics within the field of traumatic brain injury. And if there's only one thing that you take away from today's session, I do hope it's that you have a better understanding of the difference between concussion, persistent post-concussion symptoms, and chronic traumatic encephalopathy. So they are related, but different issues, and we'll get into that a bit more. But there's often a lot of confusion about these various areas. So as such, I will start us off with a discussion on concussion and persistent post-concussion symptoms, and then I will finish with a broader discussion on CTE afterwards. But before we can talk about brain dysfunction, we should level set and just get a very basic understanding of the nervous system in a healthy state. So the nervous system governs absolutely everything we do. It is the reason we can do our conscious tasks like working and walking and exercising, and then all of our subconscious tasks like breathing, controlling our blood pressure. All of these various components that happen in our body is ultimately governed by our brain, our spinal cord, and our nerves. So the central nervous system is the area that we will be focused on today. So looking here, really your brain and your spinal cord, with a predominant focus on your brain this evening. And then in terms of the actual cells in your brain, there are various types, but for our purposes, we will be really focusing on what's called a neuron. And there's an image right here on my slide. So again, it's one of various different types of cells, but it's the cell that we will focus on for the purpose of concussion specifically in this talk. So we're going to look at what happens following a brain injury and what is happening in a healthy brain. So to start, what is a concussion? So a concussion is a type of traumatic brain injury caused by a bump, a blow, a jolt to the head, or by a hit to the body that causes the head and the brain to move rapidly back and forth. So your brain is floating in your skull, which means there is free movement as you are moving about the world. What's important to note is that symptoms may not appear immediately following the injury. So it is not uncommon for symptoms to appear maybe the next morning after an impact. And then again, most people do feel better within a couple of weeks, and symptoms generally are getting better over time. But in instances where symptoms do persist for more than 1 month, that is when someone would become diagnosed with either post-concussion syndrome, or more commonly known today as persistent post-concussion or concussive symptoms. And these symptoms may last for months, and some people they last years. It really is unique. But the key difference here is that concussion is that initial injury, whereas the following prolonged symptoms really encompasses a clinical syndrome of a more ongoing problem beyond the initial injury. So let's take a look what happens at the cellular level. So if you remember the neuron that we looked at a couple slides ago, here's what we're looking at in a healthy brain. So the way I like to think about neurons is almost like my phone charger. So you have your phone charger, unless you have those really fancy USB outlets in your house, you most likely have a charging cube attached to that charger. So picture plugging that charger into the wall, and this is what we're looking at for our cell body. This is where we're receiving the input and the signal is arriving. Then once we have the signal arrive, it's going to travel down that axon to another cell. So in this case, think of that as the cord to your phone charger. So it's plugged into the wall and you're transmitting electricity from that adapter through the cord. What's interesting about neurons, though, is how when they're communicating, they're actually not touching. So there's a little bit of space between the end of this axon and the next cell body. Obviously, when you're charging your phone is plugged into the phone, but for our purposes, let's just picture there's a bit of space and the electricity is jumping from that cord to your phone to charge it up. And that's really what's happening when we're looking at these chemical messages. But in this case, we have molecules called neurotransmitters. So they'll be released, and their release triggers activation of the next cell. And the process we just went over will happen in the next cell, and it will just go on and on until that message is received. But in a brain that has had an injury or there's any neurological dysfunction, this process can't happen efficiently. And the reason for that is we have these potassium ions that are exiting the cell at a very rapid rate. And why this is important is if we look at the potassium ion, it's positively charged. So if we get a lot of positive coming out of the cell, we're going to have a net negative charge in the cell body, which will ultimately impact how the electrical message is getting sent down the body of the body and in the axon of the cell, affecting communication, affecting function, among various different things. And what happens is then there's ultimately an energy crisis. So if you ever have heard someone say that concussion is ultimately a metabolic, dysfunction or an energy crisis, this is really the case. So here we have, the cell is unable to perform the function properly. We're seeing massive release of these neurotransmitters. So it's like an overload of information to the next cell, which is interfering with overall communication, which is why maybe we're having cognitive delay symptoms that are impacting how we're able to do tasks of executive function or go about our life. And it's also important to note that in this state, the cell is very vulnerable, which is why it's very, very important that if you have sustained a brain injury, your child has sustained a brain injury, that you don't put them back into a state of play or into an area where they may be vulnerable for another impact, because in this state, the cell is much more prone to cell death or more permanent serious damage, which is why we do recommend removing from play or removing from an area where they may be at risk at this case. And it may take many days for the cell to return to its normal condition. And it's also really important to note that even after several days and the symptoms are resolving, that doesn't necessarily mean that the cell is fully healed. So even if you're symptom-free, we don't necessarily know at what point your cells are fully better. And it's very likely that, there's a period afterwards where your symptoms have resolved, but your brain cells are still healing because there are, more components to work through beyond just being symptom-free. Your brain is very, very advanced, and it knows how to rewire and recircuit itself, which is why we usually do recommend additional ease after an injury, just to make sure there's enough time for the brain to be fully healed. So now that we have a general idea of what's happening at a cellular level, it's also really important to talk about some common misconceptions about concussion. These are things I find that we hear in the media or just discussion, and very important to recognize because it does impact how we respond to them. So first and foremost, you do not need to lose consciousness to have a concussion. This is something that was thought for a long period of time, and it's simply not the case. This doesn't mean that losing consciousness is not serious. It's very serious, but it just can't be the only sign we are looking for when we're looking to spot a concussion in an individual. And as we mentioned in the definition, you also don't need to hit your head when you sustain a concussion. It could be a hit to the body. Remember, the brain is floating in your skull. So any type of rapid acceleration or deceleration of your body could cause a concussion. Also, something very popular in the media, I guess we're seeing a lot of different inventions, we'll call them, in football specifically, but helmets don't prevent most concussions. This isn't to say that some helmets aren't better than others. There is advancing technology, but the helmet was ultimately designed to prevent lacerations, really damage to the head, the face, and it doesn't necessarily stop the brain from moving back and forth in the skull. There are, of course, helmets that do absorb more force, but they're not going to prevent most concussions, just knowing the mechanics of a concussion. And then again, to reiterate, because it is very important, symptoms may not be obvious immediately. So if the symptoms do not arise immediately after an impact, don't discount potential injury. It may just take a few hours, if not overnight, for symptoms to present. And then we can go into the concussion protocol from there. We also know that the youth athlete is more susceptible to concussion and typically takes more time to recover. Why is this? There could be a number of reasons. There are a lot of various critical brain development periods that happen in youth that could be contributing to this. We also know that females experience more concussions than males competing in the same sport. This is something that scientists have been investigating, and various hypotheses around potential neck strength differences, anatomy differences, just various components of the game that may be different because of the anatomy of a young boy or a young girl at the time, but ultimately we're seeing a higher rate of concussion in females. And then finally, routine diagnostic imaging, so thinking about your MRI or your CT scan, they usually come back normal after concussion. This isn't to say that they're not a useful tool. Usually if a doctor is ordering an MRI or a CT scan after a brain injury, it is used to rule out more severe injury, brain bleeds, things that are very important to catch early on. But ultimately, the diagnosis of a concussion comes after an assessment of symptoms by a healthcare provider. And the signs and symptoms of concussion do range across various domains, as you can see here on the screen, when no two concussions are the same. So this makes it very difficult to diagnose and treat because there are a lot of symptoms that overlap with other injuries or disorders, but it's also very difficult on the patient themselves because usually they feel like they're isolated, that no one understands what they're going through. And this is often because no one can really see the injury they're experiencing. You don't wear a cast to school or to your sports games. And at the same time, because no two injuries are the same, it's very difficult to find people on your network that have gone through exactly what you are going through. But because the symptoms are so widespread, we do recommend a multidisciplinary approach to treatment. So think of this as really recruiting your dream team of physicians to assess and assist with the symptoms that are ongoing. So you're really putting together this puzzle with the pieces that you need to address the issues that are ongoing. Typically, in the past, you would see primary care physicians, emergency docs, sometimes neurologists as really the three main groups of individuals who would be caring for these patients. But the more we learn, the more we're realizing that there's various different specialties available and ready to treat the symptoms depending on how they arise. In general, we do follow this guideline for treatment with an initial period of brief rest, and then we make adjustments around work life, school life, contact sports participation. And then in today's day and age, always important to mention the use of electronic media, access to screens. That's really the norm now, but it's not really great for recovery. So usually that is an area that is limited as well. And unlike what was previously thought, prolonged rest is no longer the gold standard, right? We used to hear about people who, let's put someone in a dark room until they start feeling better. Let's limit all sources of stimulation to the brain and see what happens. And we've realized that this not only isn't the best approach, but can also be hazardous. So that actually may slow recovery. So this approach is no longer recommended. If anything, they just recommend a very brief period to level set. So about 24 to 48 hours of rest, and then we'll move into more active recovery. So what does this recovery mean? This really means looking at ways to slowly build up various types of aerobic exercise. So this does not mean going out and running a marathon after that 48 hours of rest, but really looking like maybe working on, slow walking, stationary bike as symptoms allow. And this not only is now the gold standard, but it's actually been shown in recent literature that it's been associated with a faster full return to sport, school, or work. So actually going through this very light activity sooner in the process has shown to have positive benefits, where before we were doing the complete opposite. Now, I wanted to highlight 3 areas of therapy that are really starting to become more used in the concussion rehabilitation. And this is because we're starting to learn more about our symptoms. And if we remember from one of those very first slides, our brain really governs everything, right? So it makes sense that our symptoms could, in theory, affect various different components of our daily life. So therapists like physical therapists, occupational therapists, and cognitive therapists have become very important in the recovery and rehabilitation of concussion, depending on the symptoms that are experienced by the individual. So looking at returning to school, and we'll follow this up with return to play, the guideline as of now is really looking at this 4-stage return to school strategy. And the whole goal here is to slowly progress a patient through these steps until they're symptom-free and able to resume their normal daily activities. We do recommend, not moving forward until the patient is symptom-free or very, very minor symptoms. And a lot of the times they do require some lay time between the stages to make sure that they are progressing. But for example, say you have a child at home, they sustain a concussion, and they're at the point now where they're able to go through their daily activities and they're not getting symptoms. This would be the time, and of course, working with your doctor, to then try some school activities. So maybe they're able to do some of their reading assignments or some of the homework outside the classroom. And this is something that would be tested until they start to see symptoms or see where that level is tolerated. And as their symptoms improve and they're able to do more, we're gradually introducing more cognitive load on the student. So they would work their way through this 4-step process until they're eventually back at school and have full academic activities. Again, this is something to work with your doctor, and it's something where they'll be able to provide documentation for the school so accommodations can be made. Similarly, the return to sport protocols follow an approach with a gradual return to play, but this time in a 6-step method. And it is important to note that there should be at least 24 hours for each step. So at minimum, if you're factoring in someone taking 24 hours of rest before going into the protocol and then working through each of these stages, at minimum, the earliest a player that would be back to a sport is 7 days. And this is only if through every single stage of this process, they had absolutely no symptoms. And this is something that we're not necessarily seeing in the media. So if anyone remembers the Tua Tagovailoa injury from last year, he returned to the game within 4 days and then suffered another injury, and it was quite catastrophic. So this is why we really recommend taking the time needed so we aren't putting someone at risk of another injury when their brain cells are vulnerable, like we were looking at in those images earlier. So switching gears, we're now going to talk about chronic traumatic encephalopathy. So CTE is a neurodegenerative disease. So different than the concussive injury and different than the syndrome that may be experienced following prolonged injury. This is a progressive disease. It builds over time, and it's really the result of thousands of impacts, not just a handful of diagnosed concussions. So what is CTE? CTE, again, is a neurodegenerative disease caused by repeated traumatic brain injuries. It's been seen in people as young as 17, but symptoms typically don't begin until years, in some cases decades, after the onset of head impacts, which really speaks to the progressive nature of the disease. And then not many people know this, but CTE was actually first described in 1928. So although it's been popularized in the recent decades, so probably mid to early 2000s, since we started seeing some of those high profile cases, this has really been around for nearly 100 years. So this was described by Dr. Harrison Martland. He had been looking at a group of boxers and he described them as having punch drunk syndrome or dementia pugilistica. So this is the earliest we can trace any literature on what we now know as chronic traumatic encephalopathy. And as important as knowing what CTE is, it's also really important to know what it's not. So CTE is not technically a dementia, although some individuals diagnosed with CTE develop dementia. CTE risk, again, is not correlated with the number of diagnosed concussions. The research to date demonstrates time and time again that CTE risk is correlated with cumulative number of impacts, so both concussive and non-concussive. We know that CTE is not caused by opiate or alcohol addiction, although we do have individuals struggling with CTE who have had experience with addiction. And then we also know that CTE is not a clinical diagnosis. So CTE right now can only be diagnosed with full certainty via autopsy, but we are seeing physicians and researchers working on trying to find a clinical syndrome equivalent so that we can start diagnosing people in the clinic. But as of right now, any diagnosis from your physician will be that of suspected CTE. It will not be a diagnosis of CTE as a definitive measure. And like concussion, the signs and symptoms of CTE are wide-ranging across various domains. You'll notice that many of these symptoms cross over with many other neurodegenerative disease, mental health disorders. It makes it very difficult to parse out what is what, which is a continuing obstacle with diagnosing CTE, is there's a lot of things that could be going on. We also know that brain injury is a risk factor for other neurodegenerative diseases, which makes this a complicated picture. And also, like concussion, we do recommend a multidisciplinary approach. So we really recommend assembling that care team, focusing on the symptoms. Just because we can't diagnose CTE doesn't mean we can't manage the potential disease and manage the symptoms. And to do that, we recommend following a paper that was co-written by our medical director, Dr. Robert Cantu, called The Management of CTE. And it outlines these various factors that you see here on the screen and how paying attention to these factors, rehabilitating within these domains, and adjusting your lifestyle, for example, your exercise, your diet regimen, are ways to manage the symptoms and have a better quality of life. So this is the kind of the gold standard recommendation of areas to be considering if someone is struggling with these symptoms that are associated with CTE and has a history of repeated brain trauma. And as mentioned, CTE is caused by the exposure to repetitive brain trauma. So it does make sense that those who've been diagnosed to date have participated in sports or had occupations or experiences that expose them to thousands of impacts over time. So these images and kind of word bubbles on the screen here show historically who has been diagnosed with CTE. We hear a lot about our cases in American football. We're starting to hear more about soccer and rugby and hockey and some of these other sports. And important to note now, we did have the first female athlete diagnosed with CTE this past year. So it was an Australian rules football player from Australia who was diagnosed. She also played rugby, but a very monumental finding in the literature to have the first female athlete diagnosed with CTE. Previously, the only females diagnosed with CTE were victims of domestic violence or intimate partner violence. And so far, based on our discussion, I'm obviously curating the discussion for you, but it may seem like it's pretty cut and dry, the discussion on CTE. But if you've been following the news or have any other stake in the game, you'll know that this is not the case. So the discussion on CTE has really been evolving for nearly 100 years. Not everyone is on the same page about the cause of the disease, but I do want to call attention to a review published in 1995. And at the time, this paper stated that it was widely accepted that repeated impacts cause CTE. And this was looking at boxers. So this paper was saying that widely accepted that the impacts, happening in boxing cause punch drunk. Then about a decade later, we start seeing cases found in former NFL, NHL, NCAA players, and we're starting to see this conversation shift again. So what once was considered widely accepted is now up in the air. And we've had others throughout the years questioning whether or not there's a causal link, whether there's enough evidence, what we can say about this. And then most recently, so last summer in 2022, I, alongside our colleagues from around the world, published a paper really outlining the framework of CTE and looking at a specific criteria that helps assess relationships between factors to assess if it's likely that there's a causal relationship. And in this paper, which you see here on your screen, applying the Bradford Hill criteria for causation to repetitive head impacts and chronic traumatic encephalopathy, we reviewed 164 pieces of literature and came to the conclusion that there was ample evidence to suggest there's a causal relationship. And this paper is open source. So that means anyone can go on the internet, download it for free, read the whole thing. We wrote it to be more accessible to more people. This doesn't mean there's not some complex science, but for the most part, we feel it does a really nice job at very plainly and simply laying out the history of CTE, where we're at now, what factors we need to consider in a way that most audiences will understand. So amongst this criteria, you have these 9 specific criterion that you measure the evidence against. And what's important about the Bradford Hill criteria, and the reason I bring this specific slide up, is because this criteria was actually used before to evaluate the relationship between smoking and lung cancer. And at the time that it was widely accepted that smoking was a cause of lung cancer, the researchers who used this criteria found evidence to support 6 of the 9 criterion you see on the screen. In our paper, we found evidence to support 9 of 9 of the criterion on the screen, which is why we were able to come to such a strong conclusion that repetitive head impacts or repeated traumatic brain injury is a cause of CTE. And following the publication of this paper, we reached out to the National Institutes of Health and we asked them to review the paper. And if they agreed with our assessment, to update their statement on the causal factors of chronic traumatic encephalopathy. And they did agree with us. So they did update their statement to say that CTE is caused in part by repeated traumatic brain injury. And just a small change in language has had incredible impacts around the world. So following the update of this statement, we saw groups around the world adjusting their criteria for CT causation in their opinion. So the NHS in the UK, the Professional Footballers Association in the UK, and the Australian Football League have all revised their statements on CT causation since this change was made to also agree with what the NIH and the CDC recognize. And this was also brought up repeatedly in a Senate inquiry that was held in Australia about traumatic brain injury. So making very wide impacts around the world at how we understand this disease. So now that we have a better understanding of what causes CTE, where we're at, how this conversation has been evolving, now we can look at a few of the key findings that really help us inform how we need to adjust our approach to contact sports to minimize risk. So the first set of studies we're going to look at are looking at the duration of play of a specific sport and risk of developing CTE. So there is evidence now in American football and ice hockey. The American football evidence is a bit more comprehensive because we have more cases. And then the ice hockey evidence is preliminary in the sense that it did come from a published abstract with the paper coming later. And it is a much smaller body of cases because we just don't have as many hockey players in the brain bank right now. But in these papers, so in 2020, a paper came out showing that your odds of having CTE increased by 30% per year of American football played. So that means after every 2.6 years of play, your risk of having CTE doubled. We also found in that same paper that players who played more than 14 and a half years were 10 times more likely to develop CTE than those who played 4.5 years. So for example, this would be comparing a child who started at 4 years old and played through high school to a child that only played for 4 years in high school. So the player that started at age 4, even though they ended at the same time, would be at theoretically 10 times higher risk of developing CTE than the player who delayed their start of tackle football and played through the same time and ended after senior year. And then in hockey, the preliminary data shows that we're seeing an odds of having CTE increase about 23% for each additional year of play. Then a study that just came out, I believe in July or August of this year, very monumental study, the largest to date in American football, was able to give us better evidence on both the number and the strength of hits and how they really impact risk. And what this study was able to do by looking at accelerometer data and then the cases we have in the brain bank is that for about every 1,000 hits, the odds of developing CTE increase by about 20%. And a bit later in the presentation, I'll be able to give you some tangible numbers about what the average number of hits a player is really taking at the high school and college level. I mean, it may surprise you how many are happening, knowing that at that 1,000 threshold, that risk is going up by 20%, and every 4,000 hits, that risk is doubling. We do know that strength of hits is also important. We don't necessarily know what the minimum threshold is, so it is important for us to also look at reducing the strength of the hits players are receiving, as well as the number, if we're looking to make the sport safer. And this really leads me into a recent initiative we've taken on. So the CTE prevention protocol is something we created in collaboration with our team around the world, the BU CTE Center, and is used as a way to understand how modifying the way we play and practice can really make a tangible difference at preventing CTE in future generations. So to further illustrate how making changes to the way we play and practice impacts overall risk, I'll walk you through this case study. This is from the protocol. And this is all the data is based on accelerometer data from various studies. So very reputable, very objective. And based on this work, we know that the average offensive lineman in high school will take 734 impacts a season. So just shy of that 1,000 threshold where we are seeing a 20% impact in risk. We also know that more hits occur in practice. You spend more time in practice, you're getting more reps in practice. Sometimes players who don't necessarily play in games are only playing in practice. So practice is a really great place to start if we're looking at modifying a game and reducing risk. So say as a coach, you recognize that there's something you need to do to, make your players safer and give them a better overall outcome. And you decide that you're going to cut half of the impacts that your players take in practice. In theory, we estimate that this would eliminate about 1/3 of the overall impacts, knowing that we're not adjusting any of the impacts someone is taking in a game. So based on the numbers we have here, we're estimating that in high school, we're eliminating, just under 250 a year, which means after high school, just by doing this, you could lower a player's odds of developing CTE by about 20 to 21%. We also know that if this was sustained through college, you could theoretically reduce the risk by 50% compared to players who had no modifications made to their play. Similarly, if we were to look at this in terms of G-forces, we can look at ways to reduce the overall force that is sustained by a player. And one way to do this that's effective is by removing drills that cause the hardest hits. So for example, the Oklahoma drill, it's known to have the hardest hits. Questionable how valuable it is for overall gameplay and peak performance. So by just removing a drill like that, you could reduce the amount of G-forces that your players are sustaining, which is also going to go a long way in helping reduce the risk of developing CTE. And like we're doing here tonight, education is very important. We will caveat that it is unclear at what age athletes should really start receiving education about CTE. We know the concepts are complicated, and the brain is just not fully mature to really understand the implication of this risk. I know personally, as a former NCAA athlete, I don't think that I thought about the risks associated with ice hockey the same way as I do now. So as a player, it was a very different conversation I was having in my own head compared to the conversation I'm having today as a neuroscientist. And I can appreciate that a lot of that is probably from being inundated in the sport, but also just my age. When I was in college, I probably was not ready to fully understand the implication of a really long-term disease, whereas I'm much more prepared to think about that now. And then to close the presentation, I'm going to walk you through 3 tangible changes that we recommend can be made to keep young athletes safe throughout their careers. So first, like we were talking about in the case study, we can change the way we practice. So we can reduce the number of drills that require contact. We can eliminate contact drills altogether, or eliminate drills that lead to the hardest hits. For example, the Dartmouth football team is a great example of a collegiate team that really just doesn't have tolerance for unnecessary risk, and they are removing contact in practice, and they're still able to perform at quite a high level. If you look at the NFL and the CFL, very similarly, next to no contact in practice once they're in the season. And again, it's not just to keep athletes' brains safe, but it's to keep an athlete's whole body safe. The risk for injury drops substantially when you're eliminating contact in practice. We can also look at changing the way we play. This is a bit more involved and is not as easy as just changing practice. There's more stakeholders to get on board, but you can reduce the number of hits by changing the rules. So in baseball, banning collisions at home plate, or in the NHL, eliminating fighting, or reducing the strength of the hits, like reducing the kickoff returns in the NFL by moving up the kick line. We can also maybe think about reducing the number of games in a season, or placing limit on the number of games to decrease exposure, or even potentially shortening games. If reducing the number of games is not on the table, is there a way to shorten games so that, again, the exposure potential is not as high? And then lastly, and likely the most impactful immediately, is we can just change the age at which youth are exposed to repetitive head impacts. So for example, USA Hockey and Hockey Canada have both delayed the introduction of body checking until age 13. This is not new. It's been around for quite some time. The FA in the UK has delayed the introduction of heading until age 12. In the US, there's a delay of heading until age 11. So various examples of how this can be done. And then in the US, although we haven't seen changes in football, the CDC does have data showing that in an average season, we can expect an athlete to sustain about 8 head impacts when playing flag football, whereas if they're playing tackle football, they'd be experiencing 378 impacts. So moving to a flag model until 14, which is what we recommend at the foundation for various reasons, that would allow athletes to develop the skills they need for the game, learn various team building and, those values that you get from playing sports, while really minimizing the amount of impacts they're taking. And then they can transition to that tackle game at a later age. So in conclusion, it's important to acknowledge that there's always risk associated with every single decision we're going to make. So at the end of the day, we just have to weigh the risk of doing something versus the risk of doing nothing. So in this instance, if we're right and CTE is an environmentally caused disease, and changing the rules of sports and how we play, how we practice, who can have contact in sport versus not, and we move forward with that, we know that we're going to prevent the majority of future CTE cases. So if CTE is caused by repeated head trauma, and we minimize or remove repeated head trauma in this population, in theory, we're preventing the majority of future cases. Now let's say we're wrong. So we're wrong that CTE is not environmentally caused. There's something that we don't know about right now, and it's driving the disease, but we still move forward and we change the way we play and we practice sports. So what's the worst that is going to happen? Well, children are still going to play sports just without head impacts. Maybe this means they're being put in different sports, more unique sports that have inherently less contact. We know will prevent millions of concussions. And although concussion is not the cause of CTE, as we saw earlier, concussion is still a very important issue. And we know by removing head trauma and contact from these sports, we will be preventing concussions. So at the end of the day, are there really any negative unintended consequences of acting on the information we have right now? We're hearing constantly that there's not enough data. We need to learn more before we can make a decision. And at the end of the day, there's no ethical way to run a perfect study to tell us who will and will not get CTE. The only way we're going to be able to do that is take identical twins, separate them at birth, force one twin to receive head impacts throughout their life, have the other twin receive none, and see what the outcome is. And that's just not ethical. We'll never be able to have that kind of study here. So we just need to act on the information that we have. And we need to ask ourselves, what is the risk of doing something now versus the risk of doing nothing and waiting? So with that, thank you all for your time. And I will give it back to Charlene.
Wow. Well, thank you, Dr. Samantha Bureau. We have got a ton of great questions and a lot of chat happening. So this topic is really important and it's bringing out a lot of really good questions. So let's just get after it and see how many we can get to, because they're varied and they're really all important. First and foremost, I think for me, also as a parent, how concerned should parents be if their child has suffered one or more concussions?
Yeah, that's a great question. So, I mean, concussion, every child is different. And that's where there's no true number that we say, if you've had this many concussions, you should just not play contact sports or you should change how you're doing things. What we tend to advise is that if your child has sustained a concussion and you notice that they're now getting more brain injuries at lower forces. So say the first concussion happens in a soccer game, maybe they went to head the ball and they hit the other player, they hit the ground, and they got an injury and they recovered. But maybe the next time they accidentally bump into the wall at home and now they're experiencing more severe symptoms. And if you see this pattern progressing, that's kind of the time to evaluate, is it still safe for them to be participating in sports that put them at more risk? I myself have probably had 9 or 10 concussions throughout my career as a hockey player, always recovered very well, and never found that I was getting them necessarily easier. Whereas we know some other people who only had a handful of concussions, but very quickly they realized that even the smallest bumps were causing symptoms. And that's something to be aware of.
Okay, thank you. That's really helpful. As a mother who's 1 year, my son had 3: tennis, football, and basketball. I am football. You can slip on a tennis ball and hit your head on the metal post. So things happen, right? Samantha, would you speak briefly to a parent who's asking about the risk and concussions of a child with self-harm tendencies, for example, with severe autism?
Yeah, another great question. This is something where we're starting to learn more about, and we do know that there is some head banging tendencies in certain populations. And these are populations where we've seen at risk for the concussive injury, but then also long-term injury, right? So we've actually had some cases of CTE, like you saw in the presentation, where the individual did have self-harm head banging behavior, and that led to thousands of impacts over their life. So there's definitely risk associated with it. I would really encourage working with your physician and various people in your community to help manage that and find ways to minimize the number of impacts where possible, because there will be long-term risk associated with that repeated trauma.
Okay, thank you for that, Dr. Bureau. Here's a question I'm pretty sure I know what the answer is going to be. Can you please speak about headers in soccer? Are they considered hits?
Yes, so that's something where we're hearing a lot more. We did have the first American female case of CTE was diagnosed in a soccer player, and we're seeing just incredible amounts of news coming out of the United Kingdom with soccer players who've been diagnosed with CTE, with early onset dementia. And we're learning that some of these players sustained 70,000 or more impacts throughout their career from headers. So heading is definitely considered a hit. It's considered a risk factor for CTE, which is why we recommend delaying heading until an earlier age when the brain can develop a bit more to reduce the total load. But we also know that heading the ball is one of the #1 risk factors for concussion in general. I think it's 1/3 of concussions sustained in soccer happen when athletes are trying to head the ball, whether it's a successful header, they slip and hit the ground, they hit the other player. So they're definitely considered hits, and minimizing them as much as possible is important. And practice is really where you have the most control. So by removing them from practice, most players don't head the ball at all in a game. You may have a couple players who are super headers and will head it all the time, but most players don't get the opportunity in a game. Whereas there's some teams who are practicing headers for 30 minutes a practice. You can imagine the amount of repetition you can get in a practice when all you're doing is heading the ball back and forth.
Okay, that makes sense. Parent asked, do mouthpieces help prevent concussion?
So very good question. Common misconception. A mouth guard does not prevent a concussion. We're starting to see some technology in mouth guards to help track the forces. But if we remember the mechanics of a concussion, the brain, again, is floating in the skull. So we're trying to reduce the acceleration and deceleration of your body in space, so that your brain isn't moving as much. So a mouth guard will not stop that and will not prevent a concussion, but they will definitely protect your teeth and will protect your lips. We've had friends who maybe have not worn them and bit through their tongue or their lips. So they're definitely a valuable piece of equipment for safety, just not for a concussion.
So you mentioned, Dr. Bureau, that helmets, many of us believe that helmets prevent concussions. If that's not true, what do you suggest for our kids who bike and skateboard? I mean, we see kids biking around town all the time wearing helmets, not with them usually clipped. That's probably a good recommendation. But is there anything that parents should do? Is there a better kind of helmet, for example?
Yeah, so various helmets have different ratings. So that's something that is starting to become more standardized, especially in sports. I'm not certain about bike helmets, but again, still a very valuable piece of equipment. They're able to absorb forces, which will decrease the overall impact on the head and the brain, and also really protect the skull, right? So that is really what a helmet is there for: protecting the skull, protecting the skin from lacerations, and exposing the brain to the elements per se. But again, because of how a concussion works, we'll never fully eliminate concussions with helmets, but we are seeing advances in technology that they can absorb forces better than others. So it gives you the best protection you're going to get from that mechanism.
Okay, thank you for that. So earlier on, you talked about the symptoms of concussion. And here's one that came in from a local neighbor. Hi, she says, I'm a speech language pathologist who suffered concussions 5 years ago and simply can't recover my old self. I'm tired of being diagnosed as depressed by neurologists. The best description of my symptoms have been captured by brain fog, as in long COVID. Could you please speak to this?
Yeah, I'm first and foremost really sorry to hear that you're still struggling. Unfortunately, this is something we see a lot. We get many people in our community who've been struggling for years with their symptoms. So you're definitely not alone. And this is something that could very well be linked to your brain injury. We see people who brain fog is a very common symptom. People just feeling that they're not quite themselves. They are just missing a step. Maybe they were really quick to do certain tasks and they just notice that it's not quite the same. And then the mental health implications. We are learning more and more every single day about the mental health implications of brain injury. And there was a wonderful study that came out of CHEO in Ottawa, Canada, that showed after a concussion, the youth in the study were 40% more likely to develop a novel mental health disorder. So they did not have a mental health disorder before, and these were quite serious. So suicidality, self-harm, very severe anxiety and depression when compared to athletes or kids that came in with just an orthopedic injury. So we know that there is implications there. I would really recommend reaching out to potentially a new physician if you're looking for help. We at the Concussion Legacy Foundation, we do offer free support. So we have a one-on-one helpline to help you find medical providers, get educational resources. And then we also offer free virtual support groups where you can chat with other people going through it and build that community, just because you really need someone in your corner supporting you and helping you through it. And we know people who've had an injury many years ago. It's most often very difficult to find care, because a lot of physicians do have a cutoff around that 2-year mark where they're seeing patients because there's so much demand for care for brain injury.
That is a really scary statistic about concussion and mental health. Is that widely known? No, I don't think it's widely known, Samantha.
No, I don't think it's widely known either. And the thing with this study is they looked at almost 500,000 kids in the study. So this was not a small study by any means. And there's also a study that came out recently in the military veteran population showing very similar outcomes where following a brain injury, very high increased risks of suicidality, various mental health disorders. And we do know that a single brain injury, based on a study that came out of Harvard, can double your risk of suicide. So it's very concerning, the mental health issues, and we really advocate, mental health practitioners as well as neurologists and other specialties that traditionally treat concussion to consider brain injury as a risk factor and a reason why some of these symptoms may be arising in people suddenly, because most people just assume that, they're in a funk and they don't recognize that, they're not broken, they're not in a funk, it's an injury and we can treat it and we can help you get better.
Wow. Okay. We're going to see if we can help spread the word. That's something that coaches and parents and kids really need to be aware of, isn't it?
Of course. I think the bringing up your teammates, looking at, someone who has a brain injury, it's not really realistic to ask them to self-diagnose or come forward and report for various reasons. They may really want to stay in the game, or they just really don't know what's going on. But typically your teammates will notice differences in you. Your coaches will notice differences, your athletic trainer. So looking out for kids who maybe got bumped in a practice or a game, and maybe they are a little off, maybe they are a bit shorter, or they are a bit more anxious in situations, just checking in on each other when you start to see changes can go a long way in getting them treatment sooner, which is more associated with quicker recovery outcomes.
Oh my goodness. Okay. Thank you. Couple more quick questions. Could you comment briefly on the sport of cheer and the risks associated with that?
Another great question. Cheer is a sport that we know to be very high risk for concussion, maybe not necessarily as high risk for CTE unless they're a flyer or someone who is really seeing that repetition. But just looking at the forces, if we're going back to that conversation about number of hits and forces, some of the forces that are sustained in cheer are incredible. I mean, we are throwing guys and girls all over the place. They're doing tumbling. It's definitely high risk for concussion. And we are starting to see more and more former cheerleaders, current cheerleaders coming through our system with brain injury, looking for support. And again, I think because it's not football or hockey or one of these sports we hear about in the news, people don't necessarily think about it as a high risk sport, but they definitely are seeing a lot more brain injury in the sport of cheer.
All right. Thank you for that, Dr. Bureau. What about resources to help a child who's still suffering from concussion impacts 2 years ago, migraines, so on? What would you recommend?
Yeah, so again, I would recommend finding a physician who really knows their stuff and really specializes in those prolonged symptoms. I'd recommend, depending on the age of the child, trying to find a peer support mechanism. What we've found with people is, although peer support maybe isn't, a drug or an official medical treatment, just having that community has gone a long way to people feeling less isolated, more hopeful that things will get better. They're able to really speak with someone who's been through it to get tips and tricks for daily living. So that combination of finding medical providers, finding community, and then really looking at lifestyle. So there's been some amazing work on lifestyle factors to improve the outcomes of brain injury, of neurodegenerative disease. So looking at, diet, where we can change that, healthy fats, like good quality food, light exercise, if tolerable, depending on symptoms, making sure we're prioritizing sleep, we're hydrating, all these lifestyle factors that are honestly very boring and most of us probably don't pay too much attention to, can go a really long way in just giving the whole body the opportunity to recover.
All right, thank you. We have one last question here I'm going to end with because this seems like such a good one. Nona asks, are there any promising treatments on the horizon to actually repair the brain from impacts or concussions?
Another great question. So we are constantly working on trying to treat and diagnose. So for concussion, there's, various options down the pipeline. I think for concussion, what's really interesting to a lot of researchers is trying to find a way to just definitively quickly diagnose a concussion without having to go through those symptom checklists. But if you're looking at the more long-term in terms of CTE as a disease, so putting it in the grouping of Alzheimer's and Parkinson's and these other devastating diseases, that is an area where substantial investment is going in not only diagnosing more definitively in life, but once we have that diagnostic marker, it will unlock the opportunity for clinical trials to see what we can unlock in terms of actually reversing, preventing, slowing the disease. And because there's so many overlaps between CTE and Alzheimer's and these other diseases, in my opinion, my background before this was in pharma for Parkinson's, and I think there's a lot to learn from CTE for these other diseases. So I think we're in a really exciting time where we have opportunity to potentially cure various diseases, if not very severely improve patient outcomes and quality of life.
Well, thank you, Dr. Samantha Bureau. This was brilliant. You've raised a lot of questions, things we need to think about, and you've given us so much great information. Thank you, everybody who was with us, and we really appreciate all the wonderful questions. We got to as many of them as we could, but we really do appreciate you, Dr. Bureau. This was a great session, and you can tell now I love these floating emojis, but thank you to you and the Concussion Legacy Foundation, and thank you to everybody who joined us this evening for a really important topic. And thank you, Sequoia Healthcare District, for your sponsorship of this special community forum. Take care, everybody. Stay safe, and we hope to see you again soon. Good night.